My name is Pilar Garrido. I'm a thoracic medical oncologist, head of the medical oncology department at Ramón y Cajal Hospital in Madrid, and also associated professor of medicine at the School of Medicine at the University of Alcalá in Madrid. A pleasure. I think that the first message is that early stage non-small cell lung cancer is a curable disease. So the goal is increase the rate of cure. For many years, we had the same standard of care. Usually start with a local treatment, surgery, and then offer a systemic treatment, chemotherapy, for those patients in which, at the moment of the resection, nodal involvement was found or the tumor was big, for instance, T4 and 0 disease. But thanks of the advance in metastatic disease, focus particularly in the immunotherapy field, but also in targeted agents, in particular in the EGFR mutated disease, we learned that we can improve the result in early stages also for this subset of patients. So now we are living very exciting time because we have new options for our patients, including immunotherapy in different scenarios in early stages, or for the subset of patients with EGFR mutation in the scenario of early disease 2 by adding osimertinib. Immune checkpoint inhibitor, in fact, represent a change of paradigm in many tumors. In fact, the first tumor in which we demonstrated the added value of using immunotherapy was melanoma, but then very quickly we learned the value in non-small cell lung cancer. So there is a clinical rationale, but also there is a preclinical rationale. In fact, we really know that PD-1, PD-L1, and CTLA-4 pathways contribute to tumor immune escape and can be targeted by immunotherapy. So there is no doubt. For instance, in non-small cell lung cancer, the first scenario was the use of immunotherapy as single agents in metastatic patients already treated. And for the first time, we learned that we can have some patients with long-term survival, even 5-year survival. Then the clinical trials moved to the first-line scenario, and in that, we demonstrated that monotherapy with immune checkpoint inhibitor, PD-L1, or these agents in combination with chemotherapy also offer a benefit in a subset of patients. Then we moved the clinical trials to the potentially curative scenario, meaning stage 3 unresectable disease. And in this subgroup of patients, based on the Pacific trial, we demonstrated that adding 1 year of durvalumab after completing chemo and radiotherapy, we can improve the results. So based on this background, we performed clinical trials in the early stage scenario, trying to improve the rate of cure. And we are really living exciting time because some of the clinical trials demonstrated adding value in this early stage scenario, neoadjuvant or adjuvant treatment. In the early stage scenarios, we can select neoadjuvant treatment or adjuvant treatment. There is some pros and cons related to each strategy. For instance, when selecting neoadjuvant treatment, we know that we can downstage the tumor and favor the surgery. We know that we can analyze the response, that we can have better way to assess the response because we have the initial biopsy and then the tissue, and we can achieve pathological complete response that we think is a good surrogate of long-term survival. But at the same time, there are some cons related, for instance, to the risk of delaying a curative surgery because around 20% of patients finally didn't go to surgery. There is always a debate if this is because of the neoadjuvant treatment or just sure this patient never could have go to surgery. And the other potential risk is adding toxicity because, as I said, we are thinking about increasing the rate of cure, but we need to be sure that we are not harming our patient. We are not transforming a patient in a chronic patient because of the immune toxicity that he can or she can suffer. So this is always a matter of debate, but in general, I would say that the pros are clearly higher in volume than the cons. But always toxicity should be taken into account. And of course, at the very beginning, we need to check that this patient, the potential patient, hasn't have any concern to use immunotherapy, because still today there are some subset of patients that they shouldn't receive immunotherapy because of previous condition. When speaking about the benefit of immunotherapy, we always need to take into account that there are some pre-existing conditions that can prevent of using, or we shouldn't use immunotherapy, for instance, in case of immune-related previous diseases. There is also a continuous debate about the potential role of using corticosteroids previous to start immunotherapy, but I know that particularly in lung cancer patients is very difficult to avoid in all our cases. But formally, I would say that for those patients with immune-related previous diseases, it's not a good idea to start immunotherapy, regardless of the stage of the patient. We are living an exciting time because we have a clinical result that offer new option for our patient in the scenario of early stage. There are different strategies. One is the neoadjuvant setting, meaning start the treatment with systemic treatment and then go to surgery. And we have a positive study, and based on this positive study, we already have approval by FDA and also EMA of this strategy. The study is the Checkmate 816. This study randomized patients to receive chemotherapy alone or chemotherapy plus nivolumab, and demonstrated was a positive study because demonstrated an increase in the event-free survival and pathological complete response that were the two main endpoints of this study. In fact, in the last ASCO meeting, some updated results demonstrated that even in the long term, meaning on long term 3 years, the results were continued favoring the combination of chemotherapy plus nivolumab in this neoadjuvant scenario. Apart from the neoadjuvant scenario, we also have some positive results in the adjuvant scenario, meaning patients up front went to surgery and then they receive immunotherapy. We have 2 approved agents, at least in the US, that are atezolizumab and pembrolizumab, because we have 2 positive trials. The atezolizumab study is the IMpower10 study that demonstrated the added value of atezolizumab after completely surgery and standard systemic treatment. This combination had been approved by FDA and EMA, although in potentially different subset of patients, while the pembrolizumab study, the PEARLS study, the Keynote 091 study has been approved by FDA, but EMA decision is still pending. The design of the study is similar, and this is also a positive study. Finally, it's true that there is an emerging strategy called perioperative perioperative treatment, in which immunotherapy is added at the very beginning, but also as adjuvant treatment. And in the last ASCO meeting, we heard from Dr. Heather Wickley the result of the Keynote 671 study, testing the role of pembrolizumab plus chemotherapy up front, then surgery, and then adjuvant pembrolizumab. And this study, again, was positive. And in this scenario, in fact, there are many other clinical trials ongoing. We already knew the early results of the durvalumab trial, the EAGAN trial presented at the ACR meeting this year, but there are many other agents such as atezolizumab or nivolumab in combination with chemo upfront, then surgery, and that adjuvant treatment. So I think that although our current present is fantastic for our patient, the future is even brighter because we have many clinical trials ongoing that probably are going to change again our standard of care in this subgroup of patients. It's true that there are many challenges. One of them is we know that we shouldn't compare the result of clinical trials, no? And in fact, the endpoint of the clinical trials in the same scenario are not exactly the same. For some clinical trials, the endpoint is event-free survival, disease-free survival, pathological complete response, median pathological response, etc. At the same time, we know that in early stage, we cannot wait years for having the final results in terms of overall survival. So there are some debate about the surrogate marker and what is the best one. And finally, we need to identify really the patients who benefit the most. And we know that the best biomarker for now is PD-L1 status, but there are also some debate about the threshold. So it's really challenging. And finally, I could say that from the clinical point of view, there is other challenge focus on the definition of resectability, because in some clinical trial, particularly for instance in the perioperative study I have already mentioned, they focus on patients with locally advanced but resectable disease. And this is not a clear concept. I think there is a gray zone between completely clear unresectable disease, completely clear resectable disease. So interpreting the result in terms of patients that finally didn't undergo surgery or the pathological or major complete response also depends on the subgroup of patients that you enroll in this clinical trial. So in fact, it's true that there are many challenges. My name is Pilar Garrido. I'm a thoracic medical oncologist, head of the medical oncology department at Ramón y Cajal Hospital in Madrid, and also associated professor of medicine at the School of Medicine at the University of Alcalá in Madrid. A pleasure. Yeah, this is a very important question because we need to know what is the patient who benefit the most for each therapy. So we need biomarker. And in fact, when speaking about non-small cell lung cancer, we need to know several things. The first one is the histology, because the chemotherapy regimen is not going to be the same if we have adenocarcinoma or squamous cell carcinoma, and this is regardless of the stage of the patient. Apart from that, we need PD-L1 status. We need PD-L1 status in patients with advanced disease because, as I mentioned, there are some clinical trials that allow the use of immunotherapy alone in the first-line setting only for the subset of patients with PD-L1 greater than 50%. So we need to know that. In Europe, for patients with locally advanced disease, based on the result of the Pacific trial, the EMA approval was focused only on PD-L1 positive. So in unresectable stage 3, we need to know the PD-L1 status in order to offer or no durvalumab for a year. And as I mentioned, based on the result of neoadjuvant and adjuvant treatment, we also need this result because, for instance, the Empower trial, the adjuvant trial using atezolizumab in Europe was approved only for PD-L1 greater than 50%. So these biomarkers are really needed. Apart from that, we know that targeted agents can change dramatically the result in subgroup of patients, mostly in non-squamous, non-small cell lung cancer with advanced disease. So in this group of patients, we need to test some genes. So for this reason, we have different guidelines. The the NCC guidelines, the FDA guidelines, and in some countries, for instance, in my country, in Spain, we have our own guidelines because it's linked to the reimbursement options we have. So, depending on the guidelines, this list of genes mandatory to be tested could be different. At least I could say that in patients with advanced disease, EGFR mutation status, BRAF mutation status, ALK and ROS rearrangement are absolutely mandatory. But usually we try to perform an NGS that allow us also to identify KRAS mutation, MET14 skipping, red rearrangement, etc., etc. This is in the scenario of advanced disease. But it's also true that currently in early stages, we need to know the EGFR status. So there are some debate about if we should perform also NGS in early stages, although our treatment is going to be different, at least for now, only in patients with EGFR mutation or not. And part of the debate also about when should this NGS be performed in patients with early stage is linked to the possibility to achieving a complete response with a neoadjuvant strategy. So in that case, we should test all the biomarkers at the very, very beginning, just in case our patient achieve a pathological complete response and we don't have any additional option to test any kind of biomarker. But this is always changing. It's a matter of debate, but the key message is that we need histology, PD-L1 status, and a biomarker for a testing gene biomarker, at least for non-squamous. Yeah, we have many data supporting the testing for PD-L1 expression in different scenarios. As I mentioned, the first scenario in which we demonstrated the added value PD-L1 expression is in the scenario of advanced disease, metastatic setting, and in fact, we have some option to be used only in patients with PD-L1 greater than 50%. For instance, pembrolizumab can be used as monotherapy in this scenario. And in fact, in Spain is the only drug reimbursed in this scenario. We can also use pembrolizumab plus chemotherapy or other agents, but this test is needed. As I mentioned, also in Europe for stage 3 unresectable disease, PD-L1 status demonstrated a higher value is the only approval for durvalumab. We cannot use durvalumab in PD-L1 negative, and also some results coming from early stages demonstrated a consistent result, some consistent result demonstrating that PD-L1 status, the higher, the best result. Having said so, there are some concern about heterogeneity that we can talk later on. Yeah, this is really relevant question because, for instance, for the initial clinical trials focus on patients already treated in advanced disease, we learned that even patient PD-L1 negative can achieve long-term survival, 5-year survival. So this PD-L1 biomarker is not the perfect, I could say so. So there are some limitations related to that, and also there are some limitations about what is because this biomarker can be heterogeneous also within the tumor, in different parts of the tumor, or even in a metastatic patient, depending on the place to be biopsied, maybe the biomarker can be different. So really we have some limitation related to that, the clinical ones, and related to the test. And then we have the issues about the immunohistochemistry system, the threshold. So there are some questions we need to analyze a little bit better in order to have a better biomarker. Yeah, as I mentioned, PD-L1 is not a perfect biomarker. It's a heterogeneous, also it's a continuous biomarker. So it's difficult to make a complete separation among a patient with a PD-L1 59% versus 49%, but we can use, or we are allowed only to use specific treatment strategies. So it's clear that we need to add more on top of that. It's also true that PD-L1 is quite robust in some clinical trials. I say so. There are some biomarkers, and there is a lot of research, academic research in this area, focus on identifying other biomarkers in tissue. But it's also true that we learn that mechanisms of resistance are different when the patient never responds to immunotherapy from primary resistance versus those patients who achieve a partial response and then progress. And it is not easy to perform sequential tissue biopsy. So to identify other biomarkers to add or to change PD-L1 in terms of tissue is really complex. This is why there is a great interest on learning what is the potential value of liquid biopsy also in this scenario. So, and in fact, there are some results, for instance, for other biomarkers that we thought some years ago that it was going to be really relevant, the tumor mutational burden in tissue, that we also know that there are some positive results in blood. So we need some biomarker, and we have some positive results of some studies, not only focus on TMB, but also focus on DDR, circulating tumor DNA, PP53, tumor microenvironment, and finally gut microbiome. And in fact, at least I think for the first time, ASCO organized a meeting within ASCO big meeting about the role of microbiome as a potential biomarker for immunotherapy. So we are trying to identify other biomarkers because we know that PD-L1 is good, but it's not perfect. My name is Pilar Garrido. I'm a thoracic medical oncologist, head of the medical oncology department at Ramón y Cajal Hospital in Madrid, and also associated professor of medicine at the School of Medicine at the University of Alcalá in Madrid. A pleasure. As I mentioned, there is a clinical rationale because most of the patients didn't achieve any kind of benefit from immunotherapy alone or even immunotherapy plus chemotherapy. We know that we have long-term survivors, about 20% or even 30% in patients with PD-L1 greater than 50%, but it means that we need other options for most of our patients. So there is a clear rationale. There is a rationale for those patients who have primary resistance, but also for the patient who had secondary resistance. And for the preclinical point of view, we also know that the exhausted T cell present some other molecules that can be targeted by other immunotherapy agents, and that can help to reverse this resistance to immunotherapy. So there is a huge investment on academic research trying to look what is the best combination or new targeted agents within immunotherapy to be added to solve this problem of resistance to immunotherapy. It's fantastic to have different options. There is a rationale behind using immunotherapy combination. We know that we can achieve good long-term results in selected patients when using monotherapy with pembrolizumab or other agent. But in general, we use combination with chemotherapy. But for instance, we know the result of the CheckMate 9 LA trial testing nivolumab, ipilimumab plus chemotherapy in the first-line setting. And during the last ASCO meeting, we learned that the 4-year result demonstrated added value, particularly in two subgroups of patients, squamous cell carcinoma, that are subgroup of patients in which we have usually less options, and also in patients with PD-L1 negative. Very surprising, let's say, but this is true. So there is a clear rationale for testing PD-L1, but also for thinking about different combinations regardless of the status. And on top of that, we know that there are new drugs coming, and we will need to identify the different algorithms depending on the results and depending on the performance status of the patient, the histology, and the final PD-L1 status. Yeah, there are a lot of research in this area. For instance, we know that at the moment of resistant disease, there are some other molecules that can be targeted. There are some clinical trials focused on TIGIT, LAG3, TIM3, that are some of these molecules that appear at the moment of resistance. This is also true that not always the robust background based on the preclinical data really link to the result in clinical practice. In fact, there are some agents, for instance, focused on TIGIT. The first one that was explored in clinical practice was tiragolumab, and although the result of the phase 2 study, the CITYSCAPE, the results were modest but good enough to start a phase 3 trial. Unfortunately, the result of the phase 3 study, the skyscraper one, the results were negative. But it doesn't mean that TIGIT as a target is not good enough, because there are many other companies testing other anti-TIGIT agents, and we already have some initial results very promising. Apart from that, focus on LAG3, also the same. We have modest result of agents, of the result of a randomized phase 2 study presented last year at the ASCO meeting by Dr. Philippe, with some modest but interesting results, because at the end we need to advance in this scenario. And I would say that most of the company currently are focused on identifying the best additional immunotherapy agents to be used alone or in combination with standard anti-PD-1, PD-L1 agents to solve particularly the scenario of progressive disease, but also to cover the potential immunoresistant at front by testing this combination in the first-line setting. Because another problem in clinical practice we have is that maybe when testing this new combination in patients very, very treated, in fact, in this scenario of T-cell very exhausted, is not the best scenario in which we can offer signal enough for a combination to be explored in other scenarios. So we have a lot of debate about not only the drugs to be used in combination, but in what is the best scenario to be tested for the first time. We are living the era of antibody-drug conjugate and bispecific agents. Of course, there are a lot of drugs coming, and it's very, very interesting because this is due to the advantages of new technologies that allow to merge the good things of the antibodies and the chemotherapy. So I think we are really excited about the potential of these new drugs. It's also true that these drugs are coming at the price of different toxicity profile, and this toxicity profile can be not easily managed in clinical practice, at least the first cycle. So we need to know how to manage, but the results are really interesting in different diseases, not only in lung cancer, and we have a lot of hope about some of them can modify our standard of care. Another exciting point of this antibody-drug conjugate is that this drug can be also used in combination with PD-1 or PD-L1 agents. And in fact, there are some clinical trials exploring this combination. For instance, we know some studies testing Dapo plus pembrolizumab in patients with PD-L1 greater than 50%, or Dapo plus pembrolizumab plus chemotherapy in patients with PD-L1 below 50%. So it's not only about testing the potential role of antibody-drug conjugate alone, but also in combination with the standard drug we have for immunotherapy. So really exciting time. Yeah, very good question. Maybe this is the future, but I am really pragmatic always. So I think that probably is going to be an option because there are some emerging data, but we need to wait until having results before thinking that this also is going to change our clinical practice.